From the Toronto Star, I'm Adrian Cheung, and this matters.
Now, with respect to the Indigenous people, we're very concerned, and we have been very concerned from the outset about the vulnerability of those communities.
That's Prime Minister Justin Trudeau speaking through a translator about how Indigenous communities are bracing for what could be the worst yet to come. The coronavirus doesn't discriminate. That's true. Anyone can get it, and anyone can die from it. But people and the social systems we've built, they do discriminate. When it comes to healthcare and health outcomes, there's no question that, on average, Indigenous communities are at a huge disadvantage. First Nations, Inuit and Métis people, on average, have a lower life expectancy and a higher rate of chronic illness like diabetes and arthritis. They're also 6 times more likely to get tuberculosis compared to the national average. Perry Bellegarde, the National Chief of the Assembly of First Nations, sums up the many reasons for why Indigenous people are worse off during this pandemic.
There's already overcrowded housing and no access to potable water. Food security becomes an issue because they're isolated in the north. We got to look at the more doctors and nurses that are going to be needed.
The coronavirus has now hit Indigenous communities in Canada, more than 24 confirmed cases across several provinces. And doctors like Canada's Chief Public Health Officer, Dr. Theresa Tam, says there's little doubt that Indigenous communities are at an even greater risk for some of the worst health outcomes in the country. Today, to help dive into this, we're talking to Dr. Janet Smylie from Toronto St. Michael's Hospital. She's one of Canada's first Métis doctors, and a lot of her work over the last 25 years has focused on the inequities of healthcare for Indigenous people. Dr. Smylie, thanks for making the time to talk during this critical moment.
Thanks for reaching out, Adrian.
So your work in public health has really focused on inequalities in healthcare, especially for how it affects Indigenous communities in Canada. With your firsthand experience, how have you seen that inequality playing out in the health of patients?
Unfortunately, even though as a country we're deeply committed to making sure that everybody has access to healthcare, particularly in emergencies like COVID. Unfortunately, that's still not the reality for First Nations, Inuit and Métis people in the country, because unfortunately the roots, as we've learned from the Truth and Reconciliation Commission, the roots of colonization, most Canadians would be aware of the residential school system.
What took place in residential schools amounts to nothing short of cultural genocide.
Fewer Canadians might be aware that up until 10 years ago, for example, right here in Ontario, in Northern Ontario, there was actually 2 hospitals in the town of Sioux Lookout. One that was for the people that lived in the town of Sioux Lookout, who were a mix of First Nations and people who had European settler ancestry, and then another one that was a separate hospital and not as nice. In fact, an old TB sanatorium, which was for the First Nations people who resided outside of Sioux Lookout.
So really a system of haves and have-nots even within the healthcare system.
That's right. And of course, I've spent my career working in diverse First Nations, Inuit and Métis communities, but more recently, over the past decade, I've been mostly here in Toronto. And that's another area where old colonial systems seem to still affect common and current day health services. Actually, the city of Toronto has about 70,000 First Nations, Inuit and Métis people. So it's actually the largest population of Indigenous people in the province, but actually there's very few health services for that large number of people in the city. Of course, we have amazing and groundbreaking examples like Anishinaabe Health Toronto, but that's one health clinic trying to serve 70,000 people. So what I say is health services really haven't been set up with Indigenous people in mind. At a time like a pandemic like COVID, we see, unfortunately, these structural inequities emerge in real ways.
There's this academic and medical term that I want to bring up, and I know it can sound a bit clunky, but it also helps explain how conditions affect everyone's health. And that term that I'm thinking about is social determinants of health. Can you explain what that term means and more specifically how it can affect Indigenous communities?
Social determinants of health are the upstream factors that impact whether we are healthy or not. And In fact, one of the biggest ones that we hear talked about is how much money people have. Other social determinants of health would include housing, employment, education, and food security. So, of course, if we looked at an illness like COVID, we know age is a factor, but also how our immune systems function. Clearly, access to adequate housing is going to be important because it's required in order for us to protect ourselves right now. So we're all to be staying in our houses. Food security is important because right now we're supposed to only go grocery shopping once a week and maybe order food online, and the food banks are closed. But for the large majority of Indigenous people in the city of Toronto, for example, we know that roughly 1 out of 3 Indigenous community members doesn't have adequate shelter, right? So they're overcrowded or they're out on the street along with other members of Toronto's community that doesn't have adequate shelter. For Indigenous people, though, I said a few minutes ago, these long roots, so actually social determinants of health, you could think about them as the roots of the tree of health and well-being. And for Indigenous people, of course, there's other roots like colonization, right? So, and racism. These ones are intertwined roots. So we know, for example, that actually racism directly can make people less healthy, and indirectly it could influence how much money you make or whether or not you actually get housed, because unfortunately it has been shown that landlords can discriminate against people based on their appearance. And it actually can impact whether or not you get adequate health care. So this is something that's a very difficult reality to deal with, but of course was brought to the forefront by the death of Mr. Brian Sinclair, who was waiting care in the Winnipeg Health Science Centre. But again, unfortunately, still in many of our healthcare facilities across the country, somebody who is Indigenous might be coming to the hospital with an illness, but there's still assumptions that can be made and misdiagnoses where it's assumed that maybe they're actually intoxicated with alcohol when they actually have a medical concern. And sometimes they, just like anybody else, people can come to the emergency room with substance on board and have other illnesses. But what we find is recurrent stories of Indigenous people coming to the emergency room and they haven't been drinking or using drugs, and they actually are having trouble with their diabetes or they're having a stroke, and they actually get a delayed or inadequate treatment.
It's an entire social structure that makes diagnosis and treatment more difficult.
That's correct. Yeah. And we have to actually try to avoid and challenge stereotyped thinking. And this can happen not only based on differences in how I'm racializing people. We also know it's well evidenced that people with disabilities can be treated differently. People who have a large body size can be treated differently. There's gendered differences as well.
So when we apply those inequalities to this pandemic, of course, anyone can be infected with the coronavirus and anyone can become very sick. But Dr. Theresa Tam has said that Indigenous communities are at a greater risk for more severe outcomes. Do you agree with her on that?
Yes. So because of the social determinants of health, and also what happens is because these social determinants of health, including racism and colonial policies and the stressors related to residential school and a disproportionate involvement of child protection, 60s scoop and ongoing, as well as criminal justice, that kind of breaks up our families. We're not on an even playing field. And that actually will translate into a higher burden of chronic diseases. So some people may be aware that some First Nations communities, some Métis populations may have a higher rate of diabetes compared to the more general Canadian population. But in fact, I want to temper that message with the fact that we're still here. In fact, we're incredibly resilient. We're all still here. There is a way of thinking about adversity and flipping it around. So one thing is, because of these adverse social determinants and this social exclusion, and Indigenous individuals, families, and communities are more likely to have already been exposed to challenging situations in their current life or in their history. Certainly, there's living oral history still within many Indigenous communities about dealing with quarantine because we were hit hard, like all of Canada was, in the 1918 influenza pandemic, but also other infectious diseases continued to impact our communities in a disproportionate way. So like polio and measles outbreaks, communities are quite resilient. We have amazing social networks. Some of the responses that I've seen here on the ground in Toronto are incredible. Just how our health and social service providers are adaptable. We're used to having to adapt. there is a higher burden that we could imagine, especially based on the experience from H1N1, but we also actually may be more experienced in dealing with adversity. And we can already see signs of that in the rapid adaptation and mobilization and heroic things that a lot of people are just doing behind the scenes to make sure the needs of our communities and other communities are met during this difficult time.
Dr. Smylie, we've all heard from doctors and public health officials again and again that the best way to fight this is that we should all remain physically distant and we should wash our hands, again, many, many times a day. But we live in a country where clean tap water is still not available to many communities, many of them on reserves. Are those warnings easier said than done when we know the reality of what people are facing?
So yes, the physical distancing one is an issue across the board from wherever we live. For the majority of First Nations and Métis that live in cities, right, to living in remote communities, like we do not have access to adequate housing.
Housing insecurity.
Housing insecurity is going to really limit the ability of First Nations, Inuit and Métis in this country to self-isolate. People are doing amazing things, though. I've heard here in the city, there are a whole bunch of people that have been working overtime to try to create additional spaces for Indigenous and other people who don't have shelter to be able to self-isolate. But that is at a critical point right now. And some of the northern communities, I've heard of people opening up their hunting camps. I hear of chiefs taking leadership to build additional facilities or to get mobile homes into communities. But that physical distancing one is difficult. Washing hands, and the other piece is actually cleaning contaminated surfaces, right? So not only does that require running water, it also requires and would be impacted by overcrowded spaces. Because if you have 10 people living in a 1 or 2 bedroom space, then the physical distancing and making sure we wash our hands before we touch our faces will be hard. COVID is a very tricky teacher, but one thing that we do know about it is soap and water will kill it. It doesn't have to actually be drinkable water, right? Ideally, it would be water that isn't full of other bacteria that would cause skin diseases, but just soap and water will kill it. It's shameful to be here in Canada and know that there's still communities of people and our First Peoples who don't have ready access to running in drinkable water. But over the shorter term, just making sure at the very least then that everybody's doing whatever they can to get those communities access to potable water and soap so that they can wash their hands.
For Indigenous communities that are more remote or are fly-in only, do you think it's an advantage or disadvantage that they are further away in that they're physically distant, but at the same time, likely they don't have the same kind of hospitals and healthcare supports that we would have in a city like Toronto?
For every context that our diverse First Nations, Inuit and Métis people choose to live in, there's challenges and there's strengths and then there's resiliencies. So for right now, it's actually better probably in the large majority of remote Indigenous communities to be living there because COVID is not pandemic yet there, right? Like it is here in Toronto, right? But there are some cases that are starting to emerge in rural and remote First Nations communities that I'm aware of. One of the challenges is, of course, people are further away from required medical care. I think there's a critical opportunity and many First Nations community leaders are seizing it to try to actually quarantine communities and restrict access to there.
Dr. Smylie, obviously the Indigenous community across Canada is extremely diverse and it's not a monolith. We know that the federal government has a $305 million plan specifically geared for First Nations, Inuit and Métis communities. Do you feel from a public health perspective, does there need to be a more coordinated health strategy for communities across this country?
Yeah, I'm a big believer in, the first week or two of public health school, like we talk about population health needs and trying to match responses to the population size. I guess the first thing with the 305 million, and then there's a sub envelope of 15 million that would go to the majority of Indigenous people that live in the cities. If we're actually trying to plan in a population health way, that's actually a very small proportion of the funds that are being released for this crisis, and it doesn't actually match what the projected need could be. Of course, for rural and remote communities as well, is things are more expensive, right? It's much harder to get isolation space for a remote First Nations, Inuit or Métis community than it would be in theory here in the city of Toronto or the city of Winnipeg. So I guess one of the things I'll say is I think right now that the allocation of resources doesn't match the population needs. But unfortunately, this is kind of the status quo in First Nations, Inuit and Métis health and public health. And in fact, often the needs of our people in the cities are just ignored. So that $15 million envelope for as many Indigenous people that are living in the cities as living in other areas is extremely problematic as well in my mind.
Right.
And it creates internal tensions because then when there's not enough money, I wouldn't want the envelope to be shifted because it's not enough money for the First Nations, Inuit and Métis communities that are out of urban areas. The other piece that's terrible that happens in Indigenous health is this lack of accountability for Canada's First Peoples. So this idea, and it's an old idea, that if Indigenous people are living in cities, we can just ignore them and discount them. That's based on old and systemically racist policies like the Indian Act, which define who is Indigenous and who is not, and political processes where the provinces and the territories would say, well, urban Indigenous people need to be supported. They're still Indigenous, recognized in the Constitution and have inherent rights. They're the responsibility then of the federal government. And the feds will say this is the responsibility of the provinces and the territories. This is the kind of jurisdictional quagmire that led to Jordan's principle. So the idea, because there was a young disabled man, Jordan, who had to die far away from home because there was a battle between the feds and the provinces and the territories about who would fund the special equipment that he needed to be able to die in dignity in his home First Nations community. It's starting in the cities. There are Indigenous people in cities, First Nations, Inuit and Métis people who have COVID now. And that's the main route by which it's going to get taken to rural and remote First Nations communities. But there's very little resources coming to the Indigenous people in the cities outside of the amazing leadership that the local Indigenous community has shown. And of course, public health and local non-Indigenous specific agencies here in the city are overwhelmed with other issues. So we end up on the margins. So we need to just challenge ourselves and remember that First Nations, Inuit and Métis people are the first peoples of Canada. And actually, they could be your neighbor in the city, right? They can be your neighbor in a rural area, and they can be a neighboring community, a neighboring First Nations community. There's Inuit territories in the north. And we need to challenge ourselves about the kinds of stereotypes that we think about and to try to work hard. And I know there's many people in the federal and provincial territorial governments that are trying to do this, to look beyond these jurisdictions that are kind of politically imposed and get the right supports to the right people in a timely manner.
Dr. Smylie, thank you so much for taking the time to talk and also for all the work you're doing on the front line.
My pleasure.
And that's Dr. Janet Smylie from St. Michael's Hospital in Toronto. She's had over 25 years of experience of looking into the inequalities and the problems of the healthcare system for Indigenous people. That's it for today. Thanks for listening. This Matters is hosted and produced by me, Adrian Cheung, Saba Aitazaz, and Raju Muthar. Produced and mixed by Sean Pattinen, and our director of programming is JP Fozo. Our show theme music is by So Called, and our episode music is by Mike DeAngelis. We want to hear what stories matter to you. Please send us comments, questions, or ideas to thismatters@thestar.ca. Please consider supporting the journalism the Toronto Star Newsroom does at thestar.com. And don't forget to subscribe to This Matters on Apple Podcasts, Spotify, or wherever you listen to your favorite podcasts. Let's talk soon.